Good morning, everybody. My name is Sarah Booth. I'm the director of the Human Nutrition Research Center on Aging at Tufts University. It's my special pleasure today to introduce our speaker, Dr. Brent Forrester. Dr. Forrester is chairman of the Department of Psychiatry at Tufts Medical Center, director of behavioral health for Tufts Medicine, and the Dr. Francis S. Arkin Chair of Psychiatry at Tufts School of Medicine. Dr. Forrester joined Tufts University in 2023. Prior to that, he served as the chief of the Division of Geriatric Psychiatry at McLean Hospital here in Massachusetts. Dr. Forrester is a well-funded NIH researcher, and his research is focused on novel interventions for the behavioral and psychological symptoms of dementia. Dr. Forrester recently published a book, which he is going to discuss today, entitled The Complete Family Guide to Dementia: Everything You Need to Know to Help Your Parent and Yourself. So without further ado, I hand it over to Dr. Forrester. We look forward to your talk.
Thank you so much, Sarah, and thank you all for inviting me to be here today. So as Sarah mentioned, I'm a geriatric psychiatrist by training, and I've spent nearly 30 years caring for people with dementia and their families, and over the past 25 years involved in a lot of research. And what I want to do today, as you can see, one second, this is my disclosures. I've grant support from the NIH, and I consult with a few companies that are involved in geriatric care and dementia care in particular, as well as CVS Health. But what I wanted to do today was to give an overview of how we diagnose dementia today in 2025, what's changed most recently in terms of the use of biomarkers to help augment our clinical assessment of patients. I want to talk about some of the newer disease-modifying therapies that are now FDA approved to treat people with the Alzheimer's type of dementia, with a focus specifically on the behavioral and psychological symptoms, as Dr. Booth mentioned, which is my area of expertise, and the area of expertise in our field, which is managing these challenging behaviors. Some of the work we've done with electroconvulsive therapy and cannabinoids, talk a little bit about prevention, and then our Tufts memory care program, which we have now launched. So every March, which this should come out in the next week or so, the Alzheimer's Association lists their facts and figures, and it's an amazing 200-plus page deep dive into all the statistics you'll ever want to know about Alzheimer's disease and related dementias. So this was a graphic from last year's update, which is really staggering when you think about the numbers and the impact. So right now in the United States, there are about 7 million Americans living with some form of dementia. Now, only half of those people are actually diagnosed. And of the half that are diagnosed, half of those don't get diagnosed until they're already unable to pay their bills or drive. That means they're already in the moderate stage of the illness. And the disease in the brain, the process in the brain we're going to talk more about, has been going on likely for upwards of 2 decades. So what that means is we have an imperative, not only because of the rising prevalence and the cost to society and the impact on morbidity, mortality, but if we're going to do something about this in terms of prevention, secondary prevention, or to delay disease progression, we need to find people earlier. So the numbers here really speak for themselves, but I want to highlight a couple. One is the impact on caregivers. We now have 11 million Americans who are providing care for a loved one with dementia. These are unpaid caregivers, often family and friends. And the cost to society is staggering. It's currently costing the nation about $360 billion a year to care for people with dementia. This, of course, does not include the unpaid caregivers or the time to loss to work, et cetera, of those unpaid caregivers. But there's probably another $350 billion in terms of the care that the caregivers are providing. But the total numbers are going to well exceed $1 trillion by the year 2050. Caregivers are incredibly stressed from caregiving. It actually predicts morbidity and mortality in caregivers. We know that people with dementia are more likely to come from underserved populations, including Black Americans and Latinx Americans, and yet these demographics are often less likely to be diagnosed. All right. So I just want to go through a couple basic definitions, and I'm going to keep it relatively simple for the purposes of this talk. But we have a diagnostic manual in psychiatry. We call it the DSM. We're on our 5th revised version now. And what's really important to know about this is that the nomenclature changed about a decade ago. So now that we have the DSM-5, we're using a term that's not dementia. We're using 2 terms that I want to make you familiar with. One is called mild neurocognitive disorder, and the other is major. We'll call the mild version MCI, or mild cognitive impairment, and the major we'll call dementia, just for the purposes of this discussion. And the basic differences between the mild version, MCI, and dementia is that MCI, which you can see here, is defined as a change in cognition in one of many domains. That's a difference from their baseline, and generally speaking, people still have intact day-to-day functioning. So they're able to drive, pay their bills, work, social interactions, all those are relatively preserved. But this is a change from their baseline. So it's abnormal cognition, normal functioning, and it's caused by multiple brain pathologies. The Alzheimer's type being the most common, which is plaque and tangle pathology, we'll talk more about. And there are genetics that are associated with Alzheimer's disease and the Alzheimer's type of MCI. And then if you contrast that with major neurocognitive disorder, this is when there's not only a decline in cognition, but this is now when it's also affecting day-to-day functioning. And really important that this is not occurring during the time of an acute confusional state, we call it delirium, which can happen when someone has a substantial medical problem. And also when you're evaluating somebody who's got a psychiatric illness like bipolar disorder, schizophrenia, cognitive impairment are common in these illnesses and may increasingly become common as people get older. But the type of deficits we see in dementia are distinct from the deficits that we see in those illnesses, and we'll talk more about that. Also really important is that there will never be enough specialists in the field of dementia care to make all of the diagnoses and to provide all the treatment that's needed. Right now, at least in the United States, although this is pretty common around the world, is that there are 3 different types of physician clinicians that can do dementia care because that's part of their training. Geriatric psychiatrist is one, geriatricians, geriatric medicine docs is another, and behavioral neurologist is a third. And if I just talk about my own profession of geriatric psychiatry, we're currently training in the United States every year 50 new people. That's it in the whole country. So we'll never have enough people to keep up with the demand. And so what's really critical is that we start to embed diagnosis, assessment, and treatment within the primary care setting. And if a primary care clinician or even a specialist were to do an assessment, these are the basics. There's the initial assessment, there's cognitive screening, and then when do you refer to a specialist? The most important thing to make a good diagnosis, and I say this to all of our trainees out there, is to get a good history. It sounds so basic, but we have a lot of fancy blood tests. We have now biomarkers, we have blood-based biomarkers, CSF, we have brain imaging biomarkers, but at the end of the day, it's a story from the patient and also their families that tells you a lot about when did this start, what's been the progression over time, how's it affected their daily life, et cetera. We want to do a thorough review of medical problems, of medications, including over-the-counter medications that people may be taking that could be causing adverse cognitive symptoms, including common things like Tylenol PM, which has Benadryl or diphenhydramine in the PM part, which blocks acetylcholine transmission and can cause cognitive issues in young and older adults. And then we want to look for treatable medical or problems or vitamin deficiencies that may be associated with cognitive decline, and replacing them may or may not improve their cognitive decline. So thyroid function, B12 and folate deficiency, vitamin D levels, CBC, basic blood panels, et cetera, to look for other medical issues. The second is some type of cognitive screen. Now, if we screen the entire population of people 65 and above in this country in a primary care setting, we would anger our primary care clinicians because then we'd be leaving them with information that they may not know how to act on. So if all we do is screen without the first part, that initial assessment, it's gonna leave a lot of confusion because some people may have deficits that are not due to Alzheimer's disease. They could be due to one of the medical causes. or they could be depressed, or they could be using alcohol. So the full assessment is critical, but some cognitive screen is important to have a sense of how they're performing on the 8 domains of cognition, and also to do a psychiatric screen. Look for depression, look for anxiety, look for substance use disorders, those 3 major things. For the cognitive screen, the Montreal Cognitive Assessment is probably increasingly now used. It assesses 8 domains of cognition. It's a 30-point scale. There's cutoffs based on age, education, et cetera. It's translated into over 60 languages, but it takes time. And so in a primary care setting, it may be too much. A clock draw and a 3-item, word list may be enough. So anyway, but some cognitive screen is important. And then the question for a primary care clinician would be, well, when do I refer somebody to a specialist? Or if you have a parent or a loved one with dementia or cognitive concerns, when would you just start with primary care and when would you go to a specialist? First of all, anyone who's being evaluated for a memory problem or some other cognitive problem needs to have at least one brain imaging scan, a structural scan with either a CAT scan or an MRI, to look for not Alzheimer's pathology of plaques and tangles, but to look for treatable causes like hydrocephalus, a fluid buildup in the brain, or maybe this is a stroke condition that's causing the problem, or maybe there's a tumor. So you want to look for treatable causes of cognitive decline. And if there are findings that would suggest Parkinson's disease because of tremor, or because the timing has been really early on, the person's very young, this is not expected, or it's not clear what the diagnosis is, that's where referral to a specialist makes sense, and especially to have further testing like neuropsychological testing. We're going to talk more about this in a minute, but the FDG PET is a measure of blood flow and metabolism in the brain, which can be very helpful in early recognition of a brain functioning problem due to a brain pathology problem that might not yet be showing symptoms. Or it may not be clear to the clinician what type of dementia it is. So the FDG PET can sometimes differentiate between the Alzheimer's type of dementia and the frontotemporal type of dementia. An amyloid PET is, we'll talk more about, is a diagnostic tool that allows us to visualize brain amyloid in someone without having to do a brain biopsy. Thank goodness we're not doing those anymore, and not waiting until someone comes to autopsy. Now, there are many kinds of dementias. This pie chart shows the Alzheimer's type of dementia, representing probably about 2/3 of all dementias, but there are a few things to know. The earlier in life someone develops dementia, so in their 50s and early 60s to mid to late 60s, that's when we're likely dealing with one brain pathology. But the older someone is, say they first develop cognitive problems in their 80s, it's almost always not one thing. It's often that combination of an Alzheimer's problem and maybe a vascular problem with a small series of strokes or maybe a large stroke. But the second and third most common are the vascular dementia and Lewy body dementia. So vascular dementia refers for people who have had either a microvascular or microvascular, either deficit in blood flow, so they've had a clot, or they've had a bleed, a hemorrhage. Those can lead to cognitive and functional decline. But again, commonly co-occurring with Alzheimer's type dementia, especially later in life. The Lewy body type of dementia refers to people with Parkinsonian symptoms like tremor, shuffling gait, masked faces, and oftentimes their cognition fluctuates. They may look great for a period of 6 to 8 hours and look really confused later on in the day. Any type of dementia can fluctuate, but the Lewy body type really fluctuates and can be very confusing for families to understand what's going on. The other characteristic hallmark of Lewy body dementia, besides gait disturbance, is seeing things that are not there, visual hallucinations. And then you can see a whole number of other causes of dementia. The list is 60 plus etiologies long. So I mentioned MRI and PET. So what this shows you is the MRI scan is the gray, and the colorful ones are the PET scan. And the type of PET scan that's on this slide is using a radio tracer, the first one that was developed, called Pittsburgh Compound B, or PIB. So on the right-hand side, the control brains, you can see in gray a normal MRI. And on the left, in the Alzheimer's brain, you see a fair amount of atrophy, so shrinking of the brain in the gray matter. And then on the control side, you don't see the blue means there's no amyloid lighting up in the brain, whereas the amyloid brain you can see with Pittsburgh compound B, the red and the yellow, and in some cases you see orange, that all is binding to amyloid plaque in the brain. So now with an amyloid PET scan, which can be done in clinical practice these days, and if you're being evaluated for one of the new treatments that remove amyloid, it actually is paid for by Medicare and other insurance companies. If you wanted to do it on yourself for whatever reason to find out, you could, but you'd be paying $5,000+ out of pocket, and you may unnecessarily worry yourself. So I would never do that or recommend anyone doing that without clinical oversight. So this is just, I just wanted to show folks what an amyloid PET scan looks like, both positive and one that's negative. Now, to get to what I said to before, the importance of early recognition is really critical. When you think about the fact that we now have evidence from prospective longitudinal studies that the disease of amyloid plaques and tau tangles builds up in the brain for years and years before we have symptoms. So the graph on the right, if you break it down into these three stages, on the top line, which is a solid line, is aging. Like we're all going to develop some cognitive changes with aging. But they're very mild. They don't interfere with functioning. They may be annoying, like it takes us a while to remember somebody that we haven't seen in a while, or it may take us a while to remember names of people and famous actors or actresses. But you can see pretty clearly that that dotted line, which is the line that heads towards dementia, is much more steep. And there are three stages. There's the dementia stage where you have functional deficits, cognitive deficits clinically, and then you've got the disease in your brain, Alzheimer's type or other types. And we're just, for the purposes of this graph, we're going to talk about the Alzheimer's type of amyloid and tau. The MCI, again, normal functioning, but abnormal cognition with Alzheimer's plaque and tangle built up in the brain. But interestingly now, we're starting to recognize this preclinical phase. And these are people who are walking around every day with amyloid and amyloid plaque in their brain, or tau tangles in their brain, but they have absolutely no symptoms. And if you think about prevention opportunities, it's really here where the biggest opportunities may lay. And when you start to see the prospective data, you start to realize that this amyloid plaque and tau tangle buildup has been going on for upwards of 20 years before you have symptoms. So somebody in their mid-50s who's completely normal, cognition functioning, has amyloid plaque in their brain if they're destined to develop the disease in their 70s. So why do people get Alzheimer's type dementia? Well, the four factors on the top are what I would call the unmodifiable or the non-modifiable risk factors, whereas the ones on the bottom are modifiable. And we're going to get to this in a bit when we talk about the Lancet Commission report, but we can't do anything about our age. We get older. We inherit our genetics. Some people have the genetics of Down syndrome, and people with Down syndrome, trisomy 21, are all going to develop Alzheimer's type dementia if they live long enough because of their genetics. Family history also matters, but it matters more if you have somebody with very early onset illness, like in their 30s or 40s. It could be an autosomal dominant illness. Or if you have a parent with Alzheimer's type dementia that developed in their 50s or 60s. The later your mom or dad or aunt or uncle or grandparent developed dementia, the less likely it's a strongly genetic illness and more likely more modifiable risk factors. The genetics that I think are relevant here, that I'm going to focus on ApoE4, it's a risk gene, whereas the three on the right are determinant autosomal dominant genes. You get one of these genes from one parent, presenilin 1,2 or the APP gene, you get Alzheimer's disease, and you get it young, often in your 30s, 40s, or even earlier. These run in small cohorts of families around the world. ApoE4, though, is a common gene. It's a risk factor gene. You inherit one allele from each parent. The 2 and the 3 are lower risk or normal risk, and the ApoE4 puts you at higher risk, but it's not determinant. So you may have two copies of the E4, have no cognitive symptoms, and never get dementia. Or you could have 2 copies of the 3 and get dementia. So we don't use ApoE testing in clinical practice to make a diagnosis. But where we do now use ApoE testing is as a risk factor for side effects from these new therapies that I'm going to talk about. I'm going to focus on this a little bit which is, why do people with dementia and their loved ones who are caring for them, why is there this trajectory of decline? What are the factors that impact caregiver burnout? And what makes it more likely for people with dementia to wind up in long-term care settings? And if you think about it, all of the five factors outside of the circle, there's the cognitive impairment for sure, but the rest of it is treatable. It's modifiable. And three of the five buckets are psychiatric, and the fourth bucket, comorbidity, has substance abuse in it. All of these factors we can modify, and they will all help to slow decline, improve caregiver well-being, and reduce the likelihood of hospitalization or long-term care placement. Beginning in the early 90s with Tacrin or Cognex, which is not on this slide because it's no longer on the market, we have had for now the last 30 plus years drugs approved to treat the symptoms of Alzheimer's type dementia and other dementias. Donepezil, which is Aricept, is probably the most widely known. When this drug came out nearly 30 years ago in 96, it took over the market, maintains the market leadership because it's once a day, it's relatively well tolerated, minimal drug interactions, and like galantamine and rivastigmine, slow decline over time by increasing cholinergic neurotransmission in the brain. Now, all of these drugs are used. Some are approved for mild to moderate disease, some for more advanced disease, but donepezil, galantamine, and rivastigmine are used throughout the mild to severe spectrum of dementia. And they're usually co-prescribed with memantine or Namenda, which works on a different neurotransmitter system. It reduces some of the glutamatergic excessive excitotoxic effects that have, unfortunately, adverse effects on brain cells. So the combination of a cholinesterase inhibitor like donepezil plus memantine is the standard of care even today in 2025, not to cure, but to slow decline. And I often will tell family members that our goal of treatment should be to slow decline, not to cure. If we knew who is really going to respond well, we could target our therapies to a smaller population. Luckily, it's well tolerated, with GI side effects being number one. And then some people develop a reduction in heart rate or bradycardia because of its cholinergic effects. Our goals are slowing cognitive and functional decline. They may help with apathy and visual hallucinations, which can be really helpful, by the way, in Lewy body dementia, but we should not expect a cure. And if you remove the drug after someone's been stable for 6 months, they have a precipitous decline, usually, not often, and they go back to where they would have been at baseline without the drug. So these are symptomatic therapies. They are not disease-modifying therapies. They don't touch amyloid or tau tangles in the brain. I mentioned memantine already. For the purposes of time, I will not dwell on this. So what about the newer treatments, the disease-modifying therapies? For the most part, these therapies are targeting the amyloid plaque buildup in the brain or the tau buildup in the brain, and they are immunotherapies. They're delivered today as intravenous infusions, as antibody therapies that lead to they change an insoluble plaque to a soluble plaque, and then it can be cleared. We can visualize both amyloid and tau with PET imaging, as I mentioned. So let me tell you about the drugs that are out there. There are three. This one is no longer, it's still FDA approved, but it's not being developed anymore by Biogen. This was the first drug that received approval nearly 4 years ago in June. This is a monoclonal antibody therapy that was developed over the course of many years for the treatment of people with mild cognitive impairment and mild Alzheimer's disease of the Alzheimer's type. Now, as I mentioned before, if you want to be effective in slowing disease modification, actually creating disease modification and slowing decline, the earlier you start, the better. And we knew from earlier studies that all failed that if you intervene too late, when somebody already has excessive amyloid buildup and tau buildup in their brain, and there's been neuronal degeneration, atrophy, you're not going to be able to recover that. But if you get people early on before there's enough brain cell death, essentially, then there may be some hope. So the two major trials were done. One trial was positive in slowing decline. The other was not positive, but both removed amyloid plaque from the brain. And there was controversy with this decision by the FDA because they made a decision to approve it not based on its clinical effect, because it wasn't clear if it had a positive clinical effect. There was one positive study and one negative study, but because it clearly reduced amyloid plaque in the brain. And this was from their earlier study, but I show it because the picture is like worth 1,000 words, because you can see here on the left, you can see at baseline, the red is amyloid. And whether, and then 1 year later, you look at the placebo arm, the 3 milligrams per kilo, the 6 or the 10, and after a year, there's no difference in terms of amyloid plaque in placebo. But look what happens at 3, 6, and 10. It goes away. It's really effective in removing amyloid plaque. All of these drugs are. The real question for aducanumab and the others is, does it matter? Like if we have a biomarker effect, that's great, but we want to have a clinical effect. And so the FDA then decided to approve 2 follow-up drugs, not only because it had a biological effect, but also because it had a clinical effect. And so what are some of the problems with these drugs? And this came up with all of them. But I just want to introduce this term called ARIA, or amyloid-related imaging abnormalities. So what we found was that some of the patients who got this drug would get abnormal MRI findings. You can see here it's circled in red. Depending on the image you look at, it's either white or they look like these black holes almost in the brain. So they're either swelling in the brain, which is called ARIA-E, amyloid-related imaging abnormality caused by edema or brain swelling, or ARIA-H, which is a small hemorrhage in the brain. One of the theories is that the anti-amyloid effect of these antibody therapies are targeting blood vessels, and they're leading to leakage of blood vessels, either so you get swelling or you get actual hemorrhage, and that's what's causing this. Now, the good news is, almost all of the time, but not all the time, but the majority of the time when you see these MRI findings, especially the small ones, nobody has any symptoms. We see it and we know that they're there, but they don't have symptoms. Here are just some other pictures of ARIA that you can see here. Baseline on the left, post-dosing, you can see on the parietal lobe, and sorry, on the occipital lobe on the right, and then a little bit on the post-dosing follow-up over time. And you can see then it resolves. So some of these just resolve on their own. You stop the drug and it goes away. Other people have symptoms. Now, importantly, we've realized that there are risk factors for who gets ARIA. This was the second drug that got approved. This is the one that's widely used now. It's the most commonly used one now. This is the New England Journal article from a couple of years ago. This is a humanized IgG1 monoclonal antibody that binds to a specific form of A beta, the protofibrils. The phase 3 trial, that a large phase 2 trial, this is the phase 3 trial, 18 months, 1,800 participants. Intravenous infusion lasts an hour at a time. It's given twice a month, and it's given over 18 months. And the primary outcome measure this group looked at was called the CDR sum of boxes. It's a composite cognitive and functional measure. And what they found in terms of ARIA was that about a quarter of people had like an allergic-like reaction, which generally was time limited and went away with anti-allergy medication, essentially. But ARIA-H hemorrhage or ARIA-E edema happened in about 17% and 12.5% of participants, respectively. But very few of those had any symptoms. So the FDA granted it approval in January of 23, and 2 years ago, this July, full clinical approval. And they're developing a device where you can actually utilize this drug, not through intravenous infusion, but a self-administered or family-supported administered auto-injector at home, which may get approved later this year or next year, which would really reduce the burdensomeness, if you will, the barriers to receiving treatment and improving access. So when you just look at the difference between drug in green and placebo, what's first clear is that both groups decline. And again, the bottom, the x-axis here is months, 18 months, and the y-axis is change in the primary outcome measure, which is the clinical dementia rating scale. So there's clear separation by month 6, statistically significant, that persists through month 18. And what they're now starting to show is that when you stop the drug, those differences are maintained. That once you clear amyloid, it looks like you've cleared amyloid and there's been a disease-modifying effect. It's not just during the time they're on treatment. So one thing to know about with these drugs, and this was the third drug that got approved that's now on the market called donanemab, similar mechanism of action. There are differences in the outcome measures they used, and the rates of ARIA are different as well. As you can see here, they're higher. Most importantly, in terms of risk, people with 1 or 2 copies of that risk gene, the ApoE4 gene, are more likely to have ARIA. And actually, if you look at ARIA-E, is 24% for all comers, but if you've got 2 copies of the ApoE4, it's 40%. Now, again, it's still not nearly that symptomatically, but because of this, a lot of centers, including ours, well, first of all, it's a case-by-case basis, but some of the centers are actually not giving this drug. They're not administering this drug to patients who have both copies of that allele. Really interesting about this study. They decided in the study to stop the drug if the amyloid was cleared. So that the way the package insert reads for donanemab is that you can stop this drug once you've cleared amyloid after a year. And so the study went on 18 months, but some people cleared it at month 6, month 12, or month 18. So this is now approved, it's on the market, and people are now trying to decide, is one better than the other, because one's maybe a little more effective, maybe a little more side effects. And then the newer data about could we stop this drug, for example. The other one maybe treat for a longer period of time. All right. So let me say a little bit more about behavioral symptoms, because, you know, when you think about dementia, what really drives the burden of this illness, as I showed in that other picture, are these symptoms. It's not the memory loss. It's the wandering. It's the aggression. It's the paranoia and the hallucinations and the depression. And if you look at our literature, you'll get confused quickly because we've used so many different terms for this behavioral symptoms of dementia. Dilip Gisti and Sandy Finkel coined the term the psychosis of Alzheimer's disease. Some people call them NPS, or neuropsychiatric symptoms of Alzheimer's. Some call them the BPSD, which is the most widely used international term, and I'll use BPSD here. But it really includes like this whole range of symptom cluster that you see on the bottom of the slide: aggression, agitation, wandering, delusions, etc. In other words, you could see the whole spectrum of psychiatric pathology in people with Alzheimer's disease and other dementias over the course of their illness. In fact, over 60%, I would say over 90% of people with dementia at some point during their life will have these symptoms. They're common. They cause caregiver burnout, elevated morbidity, mortality. We talked about the symptoms, the prevalence. Now, they may be due to the changes that are occurring in the brain. They may be due to other medical factors. They may be precipitated by the environment and the way people interact with their loved ones or others with dementia. And despite their prevalence and their impact, as of today, there's only a single drug ever approved by the FDA for these behavioral and psychological symptoms. And it's an antipsychotic called brexpiprazole, which has been on the market for a little while for schizophrenia and bipolar disorder, but was repurposed to study in dementia. And it's for the management of agitation in people with the Alzheimer's type of dementia. Now, there's a number of different considerations before determining treatment. And the first thing that we must all do as clinicians, or if you've got family members or loved one with cognitive problems and they're acting agitated, or they have behavioral symptoms like depression or psychosis, the most important thing we do is figure out why. I mean, it sounds so obvious, right? But we throw drugs at people all the time to calm them down without knowing why they're having that problem. And these are the 3 buckets of why. It could be an environmental cause by interaction with a loved one, a caregiver, a time of day, sundowning, for example. People get more agitated and irritable and confused in the late afternoon and early evening as the sun goes down. It could be noise. It could be about the person and the way in which they interact with the person with dementia. So there's the environmental bucket, if you will. And then there's the medical problems, and these are treatable problems. And so, you know, we saw, for example, in the beginning of the COVID pandemic 5 years ago now, that the first manifestation of COVID in an older person with dementia was often not fever and shortness of breath. It was confusion and agitation. Just like urinary infections cause delirium and agitation and confusion in people with dementia. It could be electrolyte disturbances or poor sleep or constipation or pain or any number of side effects of medications. But our job as clinicians is to investigate the why. Is it environmental? Is it medical? Or maybe it's psychiatric. Maybe this is a person who had bipolar disorder their whole life. And maybe now they're developing for the first time in later life cognitive decline. But they're still at risk for recurrent mania or depression. And so they may still need recurrent treatment with those medications that have kept them stable over time. And now that their brain is changing in the setting of dementia, the nature of those medicines may change. So clinicians who work with people with dementia, and they're now developing agitation, aggression, psychosis, we need to think about, why is that happening? Is it an older illness like bipolar disorder now recurring? Is it a medical comorbidity, or is it an environmental concern? And honestly, in many cases, it's all three. I could spend hours talking to you about this topic, but I consolidated it to one slide. There are classes of medicines that we use, and we often will decide on a treatment based on the symptom cluster the person has. If they look depressed, we give them antidepressants. They look like they have hallucinations or delusions, we give them antipsychotics. That works okay, reasonably well. Like I mentioned, that only one drug is approved for agitation and dementia, and yet we often will use these other classes. But there's some that we have to be really careful with. And primary care clinicians and others often will prescribe Ativan, Klonopin. These are benzodiazepines, lorazepam, clonazepam, that do work in the short run to calm someone down. But their longer term effects, adversely impacting gait or cognition, or even mood, are not worth it. And so I would avoid this class of medicines almost entirely, unless really desperate, because of safety concerns, because of their longer term effects. We sometimes use anti-seizure medications, anticonvulsants like gabapentin, for example, but again, not a lot of data. There is a lot of data with antipsychotics. There are data now as well, antidepressants for agitation. And for the antipsychotics, we have to be careful about sedation, dizziness with standing, or orthostasis, or gait disturbance. But also, as we learned 20 years ago next month, these drugs, these antipsychotics, when used in dementia, carry a slightly higher risk of death than placebo. And again, not an 80-year-old with bipolar disorder, but an 80-year-old with dementia and psychosis, you put them on an antipsychotic, their mortality rate's slightly higher than those who go on placebo. So over the course of my career, I spent a lot of time working in specialty settings. In the last few minutes, I just want to talk about some of our research that's really focused around therapeutic advances for the treatment of agitation and dementia that's not responding to usual treatment. So let me tell you the story about Louise and her daughter, Karen, who's become a friend over the years, has spoken publicly about her mom's situation and has been instrumental in supporting the work that we've done from a public advocacy standpoint. So her mom was 67 at the time I met her, and she was admitted to an inpatient unit at McLean Hospital. Interestingly, she was diagnosed in her late 50s with Alzheimer's disease by MGH, and for 10 years had lived in a progressive state of cognitive and functional decline, and over the past year or two had become more agitated at home. Now, at the time that she came into our hospital, she had advanced dementia, she had little meaningful speech, she was assaulting her husband throughout the day and throughout the night. She was admitted to our unit after trying at least a dozen medications. She had already had for 8 years evidence of profound atrophy of both hippocampi, which is where we store new memories. And there was really no treatment that we gave her on the inpatient unit that worked. Either the medicines we gave her made her sedated and she didn't tolerate them, or they just weren't effective. We tried even more than a dozen. And so we really didn't know what to do. And so one of my colleagues, Dr. Stolier, said, Brent, there's a small literature on the use of ECT. And I said, well, why would you want to use ECT in somebody who is so cognitively impaired? It might actually even worsen their memory. And so we got buy-in from the family and from our ECT service and anesthesia. And she had 8 inpatient treatments, bilateral ECT treatments. And interestingly, and this was 2 months after being in the hospital, she was doing so much better. In fact, her aggression and her assaultiveness completely resolved. She started eating better. Her headache was mild headaches were the only side effect, and we slimmed her medicines down to 1, and she went back home with her husband. And what's amazing about the story, and I'm not going to read this whole thing, but that was her before dementia. She went back home to live with her husband, and for the next 10 years, she came back to McLean on a monthly basis for maintenance ECT. and she died now about 7 years ago from metastatic colon cancer. She lived a full decade after we first met her in the hospital, and at the point where really the only options were sedation, which would have been miserable. So anyway, it wasn't about quantity of life, it was about quality of life. And so we started treating more people like this. And there were a lot of people like this. And we started to collect data. And eventually, with colleagues at Pine Rest in Michigan, an affiliate of Michigan State, we collected this data. And this was our second published study. And again, this was a retrospective chart review, was number one study. This was a prospective study where we collected data. And we found that after the third treatment, but persisting through the 12th treatment, there was a substantial reduction in agitation on this rating scale called the Cohen-Mansfield scale. And again, the average amount of time people were in the hospital before their first ECT was 4 weeks. They had been through multiple medication changes, et cetera, and they were severely agitated. So to see anything was remarkable. So we decided with the amazing collaboration across multiple sites to apply for a grant after multiple trial and error. We were funded 5 years ago for this trial. McLean, Mayo Clinic, Emory, Northwell in New York, and Pine Rest in Michigan. MUSC is our data coordinating site. And we've been recruiting people with severe agitation in the setting of dementia. We initially had 2 arms. We had a usual care plus ECT, or usual care plus what we called simulated ECT. Simulated ECT was everything but the actual inducing a seizure and anesthesia, where we would take people down to the anesthesia suite, to the ECT suite, put an IV in their arm, and keep them one-on-one with a staff member there. But because people have been in the hospital already a month and families were really looking to get people out, it was very hard to recruit. Anyway, we are about 2 months away from finishing this trial. We're looking for no-cost extension. We've reduced our sample size and made it a 1-arm trial. We're really making this a large pilot study, extremely well controlled with the interventions that we're giving. And I'm convinced that we're going to see some interesting findings when we analyze our data over the next year. The other thing which we were noticing is that as cannabinoids started to be used by older adults more widely and became legalized in many states, and we started to look into the biochemistry and the biology of the neurotransmitter effects, the neuroinflammation, and the neuroprotective effects of cannabinoids, we started to experiment clinically on using cannabinoids for agitation and dementia, not for disease modification, but for agitation or for anxiety. And so my colleague Paul Rosenberg and I collaborated on a prospective trial based on our retrospective data. This was our first 40 patients we treated at McLean with dronabinol up to 10 milligrams a day. This is a synthetic compound, which was approved by the FDA 40 years ago already to treat HIV-induced people with anorexia related to HIV, or people with nausea and vomiting who are getting chemotherapy. And we repurposed it for agitation and dementia and found that, lo and behold, it reduced agitation on our primary outcome measure, well tolerated with an average of 7 milligrams a day. So we just completed the 7-year randomized control trial, finalizing our clinical outcome data right now. 5 milligrams in the morning, 5 milligrams in the early afternoon over the course of 3 weeks. This was originally an inpatient study, disrupted by COVID, became an outpatient study as well. This is our study flow, if you will. In order to get into the trial, you had to have clinical diagnosis of dementia with the Alzheimer's type, severe agitation, ages 60 to 95, but we excluded people who were medically compromised, who had delirium, who had seizures, who couldn't swallow medicine, or who are on lithium because of the risk of delirium. So our final sample is 75 people, 65% of whom are women, some representation beyond Caucasian, but not tremendous. And we recruited subjects across 4 different centers. Really well tolerated. I'm just going to go through this quickly. And in fact, there was some more falls, for example, in diarrhea on placebo than on drug. And luckily, we didn't see any substantial change in cognition or functioning. So in other words, 3 weeks of dronabinol versus placebo did not make people more confused or delirious or cause more functional problems. And our primary outcome measure was the agitation on the Pittsburgh Agitation Scale and on the Cohen-Mansfield, I'm sorry, on the NPI scale. And those final data is actually we're expecting this week. And then finally, I just want to let folks know, given the audience in this talk, is that a colleague of mine at McLean approached me about doing a study that would utilize some of our brain imaging capacities at McLean using proton and phosphorus spectroscopy to study the bioenergetic effects and the impact on oxidative stress of nicotinamide riboside, vitamin B3. So this is a target engagement R01 study. We're in our final year, validating the effect of NR supplementation on those with MCI and mild AD, with our primary outcome measure being NAD plus and the redox ratio in the medial prefrontal cortex as measured by proton spectroscopy. We also have as an outcome downstream effects on glutathione, measure of oxidative stress, as well as the creatine kinase activity in the brain. And then finally, as an exploratory outcome, drug versus placebo after 12 weeks, does this impact cognition or functioning? This is a complicated diagram, maybe very simple for all of you, but the whole theory here is that nicotinamide riboside would elevate NAD plus levels in the brain, which would lead to downstream effects on enhancing energy metabolism and reducing oxidative stress. Finally, and I don't need to tell this audience this, but I've been intrigued for years with the approach of what can we do for people with dementia as opposed to what we can't do. And I think the original Lancet Commission report that came out a number of years ago, but especially the one that just came out last year, is really remarkable in terms of the summary of the data, looking at these 14 modifiable risk factors on the left, mechanisms in the center, all with an opportunity to potentially reduce dementia risk by up to 45% in the world if we pay attention to these modifiable risk factors. So, and again, when I give these kinds of presentations to general public audiences, it's really all about prevention and what can we do to reduce vascular damage, the neuropathology, amyloid plaque and tangle pathology, reduce oxidative stress and inflammation, and build cognitive reserve. And the original 12 risk factors were now augmented to 14. And I think the two that were added was the visual loss here. And there was another one, I think, around physical on air pollution. Those two were the two newer ones. The other ones were all noted in the earlier Lancet Commission report from about 5 years ago. The last thing I just want to mention is to give you all a framework for now how I'm thinking about dementia care. Because the problem is so big in our country and beyond, we really need to use a different approach to dementia care. And the opportunity from a health system standpoint is by focusing on what I would call population health approach. If you think about the way medicine works today, and some people would argue it's yesterday's healthcare, but living in a healthcare world here at Tufts Medicine, I will tell you it's also today's healthcare, which is that we build care around institutions. We provide services that are paid on a per visit basis. It's called fee-for-service medicine. The more we do, the more reimbursement that we achieve. We're responsible not for holistic long-term care. We're responsible for acute care. And we get paid really well for acute care. We get paid really poorly for long-term care. And because of this fee-for-service medicine system, we basically accept, or we had up until the Affordable Care Act, this dramatic increase in healthcare costs. But when we think about this from a population standpoint, we now have incentives in place financially to incentivize building care around patients, having payments incentivize not just more care, but better quality outcome care, where people get paid based on outcomes, not just based on doing things. And now we're no longer just responsible for today's outcomes, but ongoing healthcare outcomes. And it really does help to address some of the cost issues. And if you think about a population health strategy that's going to succeed in improving clinical outcomes for patients, for the population at large, and reducing cost, while also caring for the caregivers and the clinical, clinicians, you need great mental health, You need to focus on older adults, and you really need to focus on dementia. A lot of the costs in healthcare are borne by those three things. So from a dementia standpoint, the Center for Medicare and Medicaid Services decided, in their wisdom, thankfully, to launch last summer a new payment model called GUIDE, which is called Guiding an Improved Dementia Experience. And this is an 8-year demonstration project that will allow us here at Tufts Medicine to recruit patients, really, who are being cared for in our primary care settings to receive the GUIDE intervention, which essentially will, with the goal of improving quality of life for dementia patients and their caregivers, reduce long-term care stays, reduce ED visits that are unnecessary, et cetera. And it's a combination of care coordination and care management, reducing unnecessary medications, treating the behavioral symptoms of dementia, providing support for caregivers and education for caregivers, and a monetary benefit to support respite for caregivers. So we're launching this. We've been hard at work on getting this together here for Tufts Medicine. And it's one part of what we've now launched, which is our Tufts Medicine Memory Care Center, which exists now within our neuroscience service line, behavioral health, our neuroscience and behavioral health service line at Tufts Medicine. So there are three parts to it, okay? There's the specialty memory clinic, which includes multiple disciplines: psychiatry, medicine, neurology, social work, nursing, nurse practitioners, and a dementia care navigator. Getting referrals for patients who are complex or early stage, help to make the diagnosis. And then for the subset who may benefit from these new therapeutics, we have the Alzheimer's Therapeutics Program, or the ATP, where we deliver these infusions, not just in Boston, but we actually started the program in Lowell, and it's going to subsequently be moving to Boston and Stoneyham and Framingham, which is where we have our infusion sites around the system. And then very importantly, we're going to be delivering this GUIDE intervention in primary care with the services you can see on the right. And in an ideal world, we would find people early through screening. We would have this wraparound team to support them within primary care. We would only refer those people to specialty care who really needed help with diagnosis or these new therapeutics, and that we would have a dementia navigator who's available to support people and their families throughout the journey. And that kind of gets to the final thing, which is the book. So for years, I've been talking to families about all the things that they can do to be proactive about caring for a loved one. It says here parent, but it could be a parent, it could be a sibling, it could be a spouse, because there really is no roadmap. And this was a roadmap, an attempt at a roadmap. And Tom Harrison is a law journalist who found me through a colleague at McLean. And he had a mom with dementia, and he had come up with this manuscript, and he needed guidance from someone in the medical field. And so we put together this book that was published a couple of years ago, and it's been really well received because it's not like it's really written for the public, and it's very much a practical how-to dealing with the day-to-day challenges. And in it, we really talk about the onset of illness, what to look for in a loved one, the mechanisms that we all have within ourselves that delay diagnosis: denial, minimization, it's just normal aging, things like that, being aware of that. Unlike in heart attack or cancer, there's no urgency. Like, this is a very slow, long journey, and we have to be prepared for that. But the lack of urgency, unfortunately, lulls people into a sense of safety. Well, it won't happen to mom, or it won't happen to my wife because, she's still fine. So we want to be proactive. We don't want to be reactive. We want to deal with stigma and fear. We talk a lot about the things that one can do to care smarter and not harder, and how important it is to care for caregivers. So I want to make sure, and here's some of the major issues that come up in dementia care. But I want to make sure we have some time for questions. For those of you who do a lot of research in the field, I think this is a very exciting time. We are essentially at the precipice of an epidemic of dementia because of the aging of our population. But with the advent of biomarkers, finding people earlier in the course of illness, prevention strategies that may actually do a huge amount of benefit in terms of reduction of risk or slowing of decline, new therapeutics that will likely continue to be developed that are targeting way more specifically the biological abnormalities of the illness, all of that is exciting. And at the end of the day, if we don't create a dementia care program like I just described that's scalable and replicable, we're going to be dealing with a lot of disjointed care. If you have cancer in 2025, you go to a cancer center and you get biological care, psychosocial care, research care. That's really what we're trying to do in our dementia care program here at Tufts. So thank you guys so much. I'm going to stop sharing my screen, and I'm happy to stick around, answer questions, and go from there.
Thank you so very much for a stimulating talk on such an important topic. To the audience, if you have questions, please write them in the Q&A section at the bottom of your screen. We already have questions, and I know we have limited time, so we're just going to fire away. Dr. Joel Mason's question. You mentioned that the problem of dementia in part is an issue of health disparity since the incidence and severity is worse in the Black and Latino segments of society. Do we know the basis of this? Genetic, less access to health care, poor hypertension control. Thank you.
Yeah, thank you, Joel. Really great question. I would say it's likely a combination of all of this. I think there's stigma is massive in these populations. It's massive for everyone, but in these populations in particular. So delay in diagnosis is in part because of stigma and fear and not knowing what it is and calling it something else. That's definitely one factor. There's likely as well the risk factors that are associated with Alzheimer's disease that we talked about that are vascular in origin, vascular risk factors, including diabetes, obesity, hypertension, poorly controlled hypertension, et cetera, likely also play a role. There may be genetic factors as well. Most importantly is that now that we've recognized it's such a problem, how do we engage populations where there are health equity issues in both clinical care early on, as well as research. And that's an area of great active investigation, and one here that I think we have a lot of opportunity to contribute to because of the demographics of the population we care for across our system.
Great. The next question is from Dr. Sai Das. Thanks for the excellent talk. You noted that the probability of AD development is 1 in 5 for women. Are there particular physiological windows within aging years where this is accelerated, like postmenopause?
So it's another really interesting question. I don't know the answer whether there are accelerated periods, but when I was first trained in this in the 90s, before the Women's Health Study came out, we were recommending estrogen as a way to prevent agitation in dementia, to treat agitation in dementia, to slow decline of dementia, to reduce the risk of dementia. And I still wonder whether or not there may be opportunities for protective effects from hormonal-based therapies if we could do a better job of target selection and reducing the risk of other adverse, effects of prolonged estrogen exposure. So this is an area that I think really requires more investigation, but I actually don't know if we have data on whether there are accelerated risk periods, but a really interesting question.
So the last question is from Dr. Zhangdong Wang. Great lecture, thank you. I have 2 questions. Could you comment first whether blood biomarkers for amyloid and tau, in addition to brain PET scans, could be reliable for enabling identification of Alzheimer's and related dementias at earlier stages, or monitoring disease progress and treatment efficacy? The second question is whether some of the non-pharmacological interventions, such as exercise, could be beneficial for dementias by agitation.
So in terms of the first question, we are in the very early stages of the blood biomarker revolution, I would say. These blood-based biomarkers, the most common of which that I am now working with in clinical areas and in research is called phospho-tau 217 or p-tau 217. But there's a whole series of these, and some are ratios, ABA to 42 to 40, along with p-tau 217. The bottom line is this. This is definitely the future. Right now, an amyloid PET scan costs $5,000+. It's coverable by Medicare for, reimbursable if you're going in for treatment. But it's not scalable, and it's not going to be widespread enough, and there are going to be even more problems with access. The blood-based biomarkers will be relatively inexpensive, but the real question is, how sensitive and specific are they? And so I would bet within a year or two, they're going to replace amyloid PET scan as being the gold standard. for people who are being worked up for anti-amyloid therapeutics. But here's the problem. Like right now, you could go out and spend a couple $100 and get your blood-based biomarker to see whether or not you've got amyloid in your brain. Okay. And for the most part, it correlates really well. The problem is, what are you going to do about that? Okay. You don't have any symptoms right now. You may be at risk anyway because you had a family member who developed it early, or maybe you've got some of the risk factors that I talked about. You're probably going to want to focus on even more aggressive risk factor reduction. But you'd want to do that anyway, because half the people who live to be the age of 90 have Alzheimer's disease. And according to a report that came out like a month ago, at the age of 53 in the United States, you're going to develop about 45% risk of developing dementia before you die because of the aging of the population. So everyone at the age of mid-50s has a 1 in 2 chance. Knowing that you've got amyloid in your brain or not probably shouldn't change the way you run your life. You should be doing this anyway because the risk is so high. So here's what I worry about. I worry that when in the hands of primary care, without other testing, without a workup, without the holistic approach that we just talked about, we're going to unnecessarily worry some people. And there were criteria that were released a year ago, almost a year ago now, by the Alzheimer's community that really said this is a biological diagnosis. Like up until now, it's been a clinical diagnosis where biological factors support the diagnosis. And our field is quickly moving towards making a biological diagnosis like we would with cancer. Once we have tissue, we look at it under a microscope. And then we look at the genetics and we find targeted therapies and all of that in cancer. Well, we're moving in that direction, but we're not near there. So if we apply indiscriminate use of blood-based biomarkers without a holistic approach, we could cause a lot of unnecessary stress. I mean, we could also lose out on an opportunity to do risk factor reduction anyway, regardless of whether someone has amyloid. And finally, a third of people with Alzheimer's type dementia clinically don't have amyloid in their brain. So it's not just that, right? So anyway, that's a long story. The second is, yes, I think exercise may have the best data in terms of in animal studies and even in some human studies in terms of dementia risk reduction. And for people who develop anxiety, apathy, depression can be highly effective in terms of modifying some of those psychiatric and psychological variables that are so common in dementia.
Great. Well, I thank you so very much. We've gone over time, and I know, Brent, you have a hard stop. Thank you so very much for a fantastic talk, and thank you to the audience. And I hope everyone has a wonderful rest of the day.
Thank
Take
you, Sarah.
care.
Thank you for the
Bye.
opportunity. Bye-bye.